Everybody, people still having their teas, coffees. I don't know if you want to bring them back through. Feel free to grab another coffee at any point. Great. We make a start, Sylvia? Yeah, great. Okay, so this next session is a bit of a change of gear. Some super interesting research just being presented, demonstrating a lot of the challenges of stockouts, lack of availability of the products that have been in our market for decades. Yeah, but this session is called Putting the Last First, thinking about a roadmap to newer diabetes medications. And I do want to pick up something that Austin did say, and I very much agreed with yesterday in the financing session, that to scale up a chronic disease care, whether it's hypertension, diabetes, HIV, we need simple medicines and diagnostics to do that. In HIV, we have that. We have a one pill once a day that is not non-toxic. Yeah? In hypertension, I think we're getting there. We now have an algorithm from WHO that names the molecules, is stepwise, and is a public health approach, not an individual cardiologist approach. But I'm not sure we really have quite the right tools, simplified tools, that make care really feasible and simple for people living with diabetes. We want a treatment to be both clinically effective, so we don't get the horrible complications we know people who don't control their diabetes are going to get, but we also want it to be person-centered, so people can live their lives with diabetes and, not constantly thinking about injecting themselves and with very difficult tools, every day of their lives, lifelong. So yesterday we talked a little bit about some medications and devices, so pens and analogues, which have been in the market for decades that we do not have yet access to. But just imagine there was a way of delivering insulin, for example, a patch that we just stick on our arm that responded to your glucose levels. You didn't have to prick yourself every 5 minutes. You didn't have to worry about hypoglycemia. There are lots of really exciting new medicines in the pipeline that could make managing diabetes really simple for everybody, whether you're in the US or the UK or Europe, but even more so for that child in rural Zimbabwe, South Sudan. Because with the tools we currently have, managing diabetes, as I think you've seen over the last few days, in these challenging settings, with the tools we have, is not easy. People are doing amazing, great work. But, and I'm going to say, in the organisation that begins with M, our actual quality of care in terms of the outcomes of the patients we're managing is not great. And so if we find back our patients in 30, 40 years' time, how many of them are going to still be alive, I'm going to say, number one, or not have renal failure, blindness, or have had a cardiac event? Can't answer that question because we don't follow our patients for 20, 30 years. So the title of this session is Putting the Last First. Thank you, Tom Elman, for the title. And just to translate that, what we're trying to say is when new products, new medicines are made available, they're developed, the research and development is done, they're approved, they are almost, I'm going to say 100% of the time, made available in high-income markets because that is where the money is made. So this year there will be I hope you all know this, people in this audience. This year there will be a once-weekly insulin made available, which will be available in the US and across Europe. When will that be available in lower middle-income countries? Jing said yesterday, 24 years, I think it was, around glargine? Are we going to wait 30 years for a once-weekly insulin, which would make everybody's lives much easier? This is the minute we're talking about for type 2, but it's coming for type 1. Are we as a community happy that we wait 30 years for people living with diabetes outside the US and Europe to have access to these tools that could simplify care, could scale up care, and allow more people to be treated effectively? So this session is really about starting to kind of launch that conversation. And we have lots of amazing activists in here today at this meeting that are activists around getting access to medicines and diagnostics for diabetes. But I think in the NCD world, where we haven't engaged so much, and hopefully we're going to start the conversation with our panel, is with the access to medicines community. Yeah, I think NCDs has been a bit of a black hole in the access to medicines community because we've been so focused on communicable diseases. And I think that is a conversation we also need to kind of think about. How can we work together to kind of push the NCD and diabetes agenda forward and not just in our silo? So I just wanted to start with a little exercise that we did with or we're starting to do with some of our projects in MSF. And we're calling it kind of the access cascade. And if I'm going to go through from left to right, but from left to right, we're really kind of going from, let me say, slightly more global targets of advocacy right through to kind of local, at the clinic level, targets of activism. But at every step, whether it's global or local, we need the engagement of people living with the disease, whether it's diabetes, hypertension, or HIV. We need the engagement of people with the disease to drive this agenda and activism. So just to quickly go through things that we could think about. So went to a new project we've just started in South Africa on diabetes, who want to improve the quality of diabetes care. And they say we don't have access to the things we need. So it's just a kind of an exercise to get people thinking around what are the different steps for the different products you want to use to provide quality care that we could maybe target to get access to the drugs you want. So right at the first is, what is the product we want? Yeah? We don't want cold chain. Do we want an injectable? I would say probably not. So what is the product that we actually want to make this simple and easy to deliver care? And then who are we asking? So there's a system called Target Product Profile, which has been used across multiple diseases, where we get people living with the disease, experts together to actually say to the manufacturers, this is what we want you to look into. Yeah. So have we done that for diabetes? I honestly don't know. I don't think so, but I think that is the starting point. Then we know there is a whole bunch of R&D going on. If you go to Novo, Lilly, Sanofi websites, you can get their full list of pipeline products. Where is that research and development being done? Nomatemba's going to speak to this a little bit from South Africa. Where is it being done? Are people from lower middle income countries being included in the research and development? And then, how much is this research costing? Because this is always a point that pharma will come to us with. Bringing a drug to market costs billions, yeah? Okay, fine, show us your budgets. There is no transparency in R&D. There's no precedent that companies have to present publicly the actual costs of developing new drugs. And this is another piece of work in the campaign that we're looking at, is transparency, clinical trial cost transparency, which is also a WHO resolution of recent years. Then we have the mapping of intellectual property. So obviously a new product, companies put patents on this. Where are these patents filed, and what are the opportunities for early opposition that will enable generic manufacture? how early, there are mechanisms, I'm not going to bore you too much with this, but there are mechanisms that companies and governments can do to say, we need this product in our population. You know, it's really our population is not well because of lack of access to this medicine. So there are things that can be done to either companies voluntarily license their product and allow generic manufacture, or governments can also have the mechanism to do that, to enable generic manufacture. And by getting generic manufacture, we increase the volumes available, and generally speaking, the prices will come down. And as I say, again, I think, with Marg mentioned in her presentation, if we are still relying on these, 2/3 major suppliers, is this a sustainable way forward? Once we've got the product with the evidence, we need that to be integrated into normative international and national guidance. That is a process. We need the medicines to be included on both WHO essential medicines list and national medicines list. And as linking with Claudia's presentation yesterday, that's useless unless the medicines are registered in the country. Yeah? Companies and countries need to make sure the medicines they need are getting registered for use in their country. Then the pricing conversation, transparency around pricing. Can we use cost of production data as benchmarking? How are governments doing their negotiations on pricing? Yesterday's last session, I'm not a health economist, but undoubtedly, we're not going to do any of this without funding, and we have to demonstrate that what we're doing is useful and cost-effective. We need a supply chain, yeah? It's hopeless having your drugs sitting in a warehouse somewhere if the supply chain and last mile is not getting them to the clinics. And then finally, at local level, we need that service delivery package, yeah? And can we simplify this? We've done 15, 20 years of simplifying a chronic disease care in HIV. Not seeing any of the same models being rolled out for diabetes, hypertension, or other chronic diseases, which I don't know, that's our fault. But I think there's lots of lessons to learn from a chronic disease that has been scaled up. So when we looked at the medicines that this project wanted it to use in the diabetes project, we tried to do like this traffic light, look at the different barriers to access for each of the products. So going back to metformin, yeah, the access barriers there are probably funding and supply chain and actually service delivery. Where if we start talking about GLP-1s, which we are talking about for the management of type 2 diabetes, the access challenges are much more to the left-hand side, and we're dealing with intellectual property, not in any guidelines, et cetera, et cetera. So it's just a way of just getting our operational teams on the ground to think about the different ways that we can approach access and what needs to be done at the international level, at national level in country, and at project level. So I will stop there. I've got, as you can see to my left, 4 amazing ladies who are going to talk through some of their thinking around access to new medicines. So Sylvia, I think, doesn't need any introduction. Next to Sylvia, we have Lina Mengane, who's a lawyer who works on rights-based approach to health. She started her career with the AIDS movement, but has worked on TB, hepatitis C, COVID. And her work, I'm going to say, her work has really meant that thousands of patients globally have access to medicines that otherwise wouldn't, yeah? In India. She's the Indian head of the global IP advisor with the organization beginning with M. And diabetes is a big problem in India. And so we've managed to get her excited, yeah, from an access to medicines angle in diabetes. So that's my one success of the last couple of months. Next to Lina, we have Nomatemba Chandy. Nomatemba is the principal scientist at Essentia, which is the research centre in Wits in Johannesburg, South Africa. Nomatoma's leading clinical trials around cardiometabolic problems in HIV, diabetes and obesity. So really useful kind of academic experience we're going to tap into there. And then finally, but last but not least, Julia Segofredo, who's the NCD's access manager at the Medicines Patent Pool. And Julia is part of a team in charge of selecting priority NCD treatment. So to do that, she needs to know what's coming. What are the candidates that we need to be looking at to license to tackle these major access challenges? Yeah? So I'm going to hand over, first of all, to Sylvia. Sylvia is a clinician, as you know. So Sylvia's just going to give us a clinical perspective of why she thinks some of these newer drugs should be being used in LMICs and what impact they could make in terms of quality of care and service delivery.
Thank you, Helen. Yeah, as you all hopefully know, I am an endocrinologist. I practice clinically in Boston, and every year I give talks to the medical students, to the residents on clinical management of diabetes. And every year I have to almost completely change my slide set, more or less, because things are changing so rapidly in the diabetes field. Over the last 10 years, the way we used to manage diabetes 10 years ago versus today is completely different. And the conversations, for me, the conversations that we have on the global sphere versus what goes on in clinical practice in high-income countries, you know, this is Europe or US in my case, you know, it is an extreme example of, you know, a middle to high income category patient. The divide is just becoming so much more extreme. And, you know, we've talked about insulin. It's taken, 100 years after the discovery of insulin, Mark's data is depressing. It's not available, right? There are amazing new drugs that have been developed, that are continuing to be developed. There's a huge pipeline of drugs that can change people's lives and simplify care. And I recognize this will take time. It will take time, but we don't want to wait 100 years. And so I thought I would, as a clinician, give a quick overview as to current treatment goals for diabetes and challenges, what the current management landscape looks like, paradigm changes, and what might be in the pipeline that could potentially in the future be useful in lower resource settings to simplify care. We've been talking a lot about type 1 diabetes, of course. It is, like, you know, we know it's one of the most rapidly fatal NCDs, and access to insulin is 100% critical for them. Most of the cases of diabetes globally are type 2. And I just wanted to say, in a nutshell, I won't go into this, but type 2 diabetes is complicated. It is a multi-system disorder affecting multiple organs. At the end of the day, it's due to insulin resistance, and in the longer term, reduction in insulin secretion. So there's a lot going on. We know about half of the people with diabetes globally are undiagnosed. And this number is just going to rise. And people are developing diabetes at younger ages, right? In 30s and 40s and 50s, in the prime of their lives. Now, the problem is that persistent hyperglycemia, we know this is just recapping this, leads to significant end organ damage over time. It can affect literally almost every organ system. Major risk factor for ischemic heart disease and stroke. Over 30% of people with type 2 diabetes have underlying cardiovascular disease. It's a leading cause of non-traumatic lower extremity amputation, renal failure, blindness. And about 40% of type 2 diabetes individuals have chronic kidney disease. Now, this is important because those 50% of people globally, in the future about 1 billion people, that have not been diagnosed, they have all of this going on at baseline. So prevention is critical, nutrition is critical, all of that. I'm not saying that that's not important, but these people have these complications, and these newer therapies have significant benefit in this regard. So just on the right, the image, just to say the macrovascular complications, we call them. So the complications due to, essentially clogging up of the larger arteries. strokes, heart attacks. Those are the main cause of death globally in general, but also especially amongst populations with diabetes. The microvascular complications, the renal disease, the retinopathy, the blindness, the nerve pain, that may not necessarily kill someone, but it sure will make your life miserable. If your feet are burning and there's pins and needles and stabbing pain in your feet, or you're blind, that will make your life very miserable. And we know we can reduce the risk of those complications or even completely prevent them with good glycemic control. We know that especially for the small vessel complications. What's less clear is the impact of glucose lowering alone on cardiovascular disease. Data does suggest in the long term, 10, 15 years later, it does seem to lower cardiovascular risk if you address it early on. However, for example, heart failure, heart failure is very prominent, a prominent complication of type 2 diabetes, and the degree of A1C lowering does not seem to affect heart failure at all. That's the current data that we know. And there are potential concerns and adverse events. There were some studies showing higher mortality rates in people with intensive glucose lowering. So we've been trying to strike our happy balance between glucose lowering and avoiding, these adverse events. And the model thus far in type 2 management now has been predominantly glucose-centric, lowering the blood sugar. So you start with metformin, then if your A1C is not where you want it to be, typically less than 7%, but it varies from guideline to guideline and person to person. You might add a second drug, et cetera, et cetera. The problem is, we know, and we have to be realistic, that achieving a glycemic target is very, very hard to do. Very hard to do. In the United States, about 50% of people, in the United States, and even in Europe, I think it's like 30% of people, do not achieve the goal that has been set for them in their A1C, be it less than 8 or less than 7% or whatever it may be. So it's hard to do. And I thought this statistic was so striking, the GRADE trial, which, the details of that I will say are irrelevant really at this point, but it was a 5-year clinical trial looking at different diabetes drugs and kind of time to failure on those drugs and when you have to add a second drug. This was a very controlled clinical trial setting where people were meeting with clinicians constantly, very, consistently. Only 71% of the participants at the end of those 5 years achieved their goal A1C, did not achieve that A1C of less than 7%. So the majority after those 5 years did not reach that even with this intensive clinical trial. And on the bottom right, you see kind of the A1C levels going up across the board. So my point is that A1C alone is not the answer. It's very important. Glucose is very important. I don't want to minimize that. But it's not all about the glucose. And we need to think a little bit more broadly and manage that residual risk. And so in a nutshell, in 2008, the US Food and Drug Administration issued new guidance. There was concern about rosiglitazone in particular. It's a type 2 diabetes management drug that had higher cardiovascular risk. So the FDA recommended large cardiovascular outcome trials for all type 2 diabetes drugs in the future. And the drugs that were developed showed these two drug classes, SGLT2 inhibitors and GLP-1 agonists, across the board were safe, cardiovascular-wise, and some of them even reduced mortality significantly within just a few years of the clinical trial, 3 to 5 years. There was a significant benefit. And so that shifted the entire conversation now, where whenever we see someone with diabetes, and this to me also is true for type 1 or type 2 diabetes, you look at, I want to help you protect your organs from the damage of diabetes. At the same time, I want to help lower your blood sugar and control your weight. You look at the person-centered kind of goals of care, and you address these kind of, in a way, separately, but together. And so these SGLT2 inhibitors, sodium glucose transporters, these are I'm just going to show you one slide on this. These are tablets. Examples are canagliflozin, empagliflozin, dapagliflozin. They reduce your A1C by about 0.5%. But what they've been shown to do very early on is significantly lower the risk of death from cardiovascular causes, 38% lower risk. You see the curves split right away within a short period of time. It lowers your risk of heart failure by 36%, chronic kidney disease by 34%, whether or not you have diabetes, so cardiology, nephrology, endocrinology, all using these drugs leads to weight loss. And in and of themselves, if not paired with insulin, no hypoglycemia. So safe to use. GLP-1 receptors, I won't go into this, just to say it's a hormone your intestine secretes and addresses all these organ systems. It's quite impressive what these drugs will do. And there too, the cardiovascular outcome trials showed significantly lower risk of cardiovascular death, non-fatal heart attack, non-fatal stroke. And in the United States, their FDA approved 3 of them, the ones with a heart, to reduce your cardiovascular risk at baseline. So if I have a patient that I'm seeing that has diabetes and a stroke, I will immediately think of a GLP-1 agonist to help them lower their risk. This is just to show you comparative effectiveness from an A1C lowering perspective. You'll see the top 3 GLP-1 agonists for type 2 diabetes. Again, they're the most effective medication for A1C lowering, even above basal insulin. I won't belabor this, but you've seen the headlines, a lot of negative press around the GLP-1s, but they are incredible drugs. Most of them are weekly drugs. These are game-changing drugs for people. They use them once a week, a lot of the time. Here's one example of an Eli Lilly product, Trulicity. It's not necessarily environmentally friendly, I will say, but nonetheless, it's a weekly injection that is not associated with hypoglycemia, that you can use in people on dialysis with liver cirrhosis, leads to substantial weight loss, reduces cardiovascular risk, and even may help with fatty liver disease, obstructive sleep apnea. They're looking at it for Alzheimer's anyway. And people come off insulin. I have patients with type 2 diabetes who can completely discontinue insulin. This just to show you some differences. In the interest of time, I won't go over it. These drugs are extraordinarily expensive in the United States and everywhere. This is Helen's paper again showing that they could be produced potentially at a lower cost. And I know these are early days. These drugs have just been developed. I understand innovation is expensive, but I think we can do better. The costs could be lower. And the good news is that in the pipeline, so these are injectables that I was telling you about for the most part. There's one oral GLP-1 agonist, but it's not absorbed well. You have to take it fasting, all this stuff. There are multiple, I'm only listing 2 small molecule GLP-1 agonists that you don't need to take fasting, that seem highly effective, that are currently in late phase clinical trials. These could potentially be produced very low cost and be highly effective for people with type 2 diabetes. CagriSema, another drug in the pipeline, highly effective. A triple receptor agonist, also in the pipeline, leads to about a quarter of someone's weight loss, could lead to a quarter of someone's weight reduction. So anyway, my point is innovation is huge. And these are our priorities in terms of diabetes care: reducing morbidity and mortality, number 1, improving quality of life, functional status, lowering hypoglycemia risk, and making treatment burden as easy as possible. This is the once weekly insulin that Helen was referring to. It's going to come out any day now. I think it's already available in Canada, I believe. It's a once weekly insulin that I think will just make someone's life easier if you don't have to inject yourself every single day. And there are glucose-sensitive insulins in the pipeline. And so just to summarize, I'm probably way over time, I apologize. But there's been a big shift in terms of the way we think about diabetes. The stepwise approach is out the window. That is not the way forward. We are now thinking about a cardiorenal metabolic approach that's individualized and personalized. There are new medications out there that significantly lower cardiovascular and renal risk, whether or not people have diabetes, quite frankly, that are, regardless of A1C or metformin use, beneficial, that can minimize the treatment burden. Weekly, you don't have to even monitor your glucose if you have type 2 diabetes and you're just, let's just say, on a GLP-1 and or an SGLT2 inhibitor. Not critically necessary. And at the end of the day, if we think about the person, diabetes affects people's lives 24/7, 365 days of the year. If there are tools or ways in which we can simplify their lives and make it easier in any way, form, or shape, I think we need to try to do that, especially in very low resource and humanitarian settings where life is hard and they may not have access to a variety of other resources. And so anyways, I will hand it back over to Helen. Sorry for all that long
Sylvia, you
stuff.
don't have to apologise at all. Thank you. I'm always learning every time Sylvia presents that. And just as a point on the costing, the cost of a monthly GLP-1 could be less than the cost of insulin for those people who need insulin in type 2 diabetes. Yeah. So actually, there could potentially be some cost savings, as well as it potentially being an oral medication, doesn't need injecting, in the future won't need cold chain. Yeah. And type 2 diabetes, is millions of people globally. Okay, now I'm a bit confused who's next. If you just go to the next slide. Nomatemba, excellent. So Nomatemba, over to you. And I really want to hear what you think South Africa's got to contribute to this conversation around access to diabetes medicines.
Morning, everyone. So my institution receives research funding from Novo Nordisk for a CagriSema study, which is really exciting as a molecule that we hope will be there. Okay, so this is moving a little bit too fast. So I work and live in South Africa. South Africa is known as being at the epicenter of the HIV epidemic. We have roughly 8 million people living with HIV, and we consume 20% of the world's antiretroviral treatment. So you can see on that heat map that Southern and East Africa is where most people with HIV live, and that's roughly about 3/4 of people living with HIV globally. So what I'm going to be talking about today is that what have we learned from a public health approach on an approach for NCDs from what we've learned from HIV. So I think, so the big thing in South Africa, if you look at the people who are angry over there on the left, is that South Africa, we delayed, and this had a human cost. So approximately 400,000 people died because of a delay of antiretroviral treatment in South Africa. And with that, our epidemic went exponentially. And this was really our president at the time. If you can see the cartoon over there, our Minister of Health at one of the AIDS conferences had a stand which had beetroot and African potato as an alternative to antiretrovirals, which is totally unacceptable. So 190,000 infections happened because of that delay. So there's also a human cost for delay in life-saving medication. So using this background, what can we learn for NCD care? So this is our evolution. Sylvia talked a lot about diabetes medication. This is where we are in the HIV world. So 40 years ago, we didn't have much. We had monotherapy. The drugs were toxic, difficult to take. So where we are in diabetes care and HIV care, it's like HIV treatment just gives us what has been in the pipeline and also how long it took to get us there. So where we are now, we've got easy to take, very well-tolerated medications. We also have got new and exciting molecules. We've got BNABs, we've got long-acting injectables that really are game-changing treatment for people. So instead of taking a daily treatment, which is affordable, roughly about $75 per person per year, which is fantastic, to these newer injectables that you're taking every 2 months, some of them that are on the horizon, such as lenacapavir, you're taking every 6 months. So HIV care has changed so much. When I was a junior doctor houseman, we were having people coming to hospitals in wheelbarrows, negative CD4 counts. The average person that we see living with HIV comes in with a good CD4 count, they're generally well. And these are people in care. Of course, people outside of care are not doing as well. So in a short space of time, despite our delays, we've got good medication, we've got good systems to deliver it, and we've got good guidelines for it, and it's very affordable. So, how did an HIV physician stand in front of you in NCD care? It's because of this study. So, this is where treatment emergent obesity was described in a clinical trial in the world. So, this is called the ADVANCE trial. For 5 years, we followed up roughly 1,000 people. So, women to the left, men to the right, opposite for you. So, this is looking at how much weight people gained over 5 years. So the blue is a treatment, which is a TAF-based treatment. The orange is our current standard of care. And then the green is what we used to give people before. So as you can see, there's weight gain for both men and women across approximately 5 years. But with this, we are seeing other complications. So HIV care, yes, we've got gaps, but generally it's not a difficult disease if someone comes into care and they take treatment on time. But now I've learned how to look at diabetes care, hypertension, and so forth. So in our cohort, when people started off, about 10% of people had hypertension. By the end of 5 years, it was closer to 40%. Diabetes, and this is a fairly young cohort, so the median age is approximately 40 years at the moment. So this is in relatively young people. Weight gain, weight has gone up by about roughly 10 kilos in women, and there's no plateau as yet. So we're still following up our cohort. And with this, we're having a lot of obesity-related complications, including diabetes. And this is coming in a background of South Africa where diabetes is the biggest killer of Black African women, and hypertension, type 2 diabetes are now in the top 4 leading causes of death. So this is a difference from before it was TB, which was a leading cause of death. And about 70% of people are living with obesity, roughly 25% with hypertension, and 6% or so are living with diabetes. But it takes about 5 to 8 years for someone who is in care to be diagnosed for diabetes. So this is someone in care who's coming for their HIV medicine, but glucometers are not there, hypertension medication. So we've done well in one disease area, but in the same population, we're having patients coming in and not being managed across other diseases. So we've got an escalating NCD crisis. So this is a map that was released by the World Obesity Federation, World Obesity Day. So as you can see, the darker map, which is a lot of low and middle income countries, obesity is a crisis in the Africa region and other low and middle income countries. And the toll is great. So a lot of deaths from non-communicable diseases on the horizon. Childhood obesity is quite high. South Africa is in the top 10 countries of childhood obesity. So we have this looming NCD crisis that we're not doing much about. And our systems, the economic toll has been talked about. We are not prepared for this crisis that is currently there and it's to come. The cost of inaction is high. So again, as you can see with this, if you're looking at the Africa region, which is in the deep purple, so that's the first bar. So if you look at type 2 diabetes compared to other regions, if you're looking at heart disease, cancers, and stroke. So the Africa region, we're in trouble indeed. And if you're looking at people with obesity and overweight, in the African region, currently we are looking at about roughly 143 million. By 2035, a decade from now, that will effectively double to about 200 million. So in the context where we're looking at about 30 million people living with HIV, this is a big problem that we have coming, no pun intended. So what are the lessons that we've learned from the HIV epidemic that we can look at the NCD pandemic? So there are a few lessons. First of all, just like HIV, there's a lot of stigma. The reason that you have diabetes is because you don't exercise, that you eat certain foods, and so forth. So there's a lot of individual blaming on the person. But as a public health approach, I call it the KFC index. In South Africa, we've got a KFC for every 60,000 South Africans. This is before you add in all those things. I don't think there's anything else for any 60,000 South Africans. I remarked when we took a walk yesterday that I think we only saw one McDonald's. This was being in my neighborhood. I would have passed at least 10 or so when we went for dinner. So we're under assault. Even when you go highly processed foods, targeting towards children. So, and we saw the thing about Nestle, about formula having sugar in the Africa region compared to other areas. So as Africans, we are in trouble, but we're still blaming individuals, right? It's your problem. You are not able to manage it. So from HIV, for us to do that, you have to look at a public health approach. The drivers of HIV for young women, for example, you live in a poor environment, you don't have economic opportunities and so forth. Those are the social drivers. So we have to look at NCD care in the same way. Secondly, biomedical interventions, while they're great, and we've got a lot of things on the horizon, and they're important, we do need medications, we do need them at a good cost, but we cannot treat our way out of the NCD epidemic because we still have to do the other things. So in our package of tools, because some people are like, oh, diet and exercise. If you've got hypertension, if you've got all those things that you need in your toolbox, you do need good drugs that are affordable, that are easy to use, that don't make you sicker. So in that toolbox as well, we need to have drugs, but we also need to do the other things as well. The other thing is that you need political will, you need civil society to push, and this is what we're able to do. So this is something that an organization that I work with called HELA, the Food Justice Coalition. So they went to Parliament, and this was again talking about, and these are a lot of HIV organizations. You know, we had a talk and I asked if anybody in the room, raise your right hand if you've got an immediate family member that's got diabetes or hypertension. I think with the exception of 2 or 3 people, everybody lifted up their hand. So but what we're able to push with HIV is that our governments took a long time, they were complacent, etc. It was people who stood up, because I think it was someone who mentioned it yesterday that we are not convincing anyone in this room. I think with the exception of a few different things, we're aligned. We're aligned on what we need as countries and communities around NCD care. But how do we push our governments? How do we hold them accountable? And the cost, I'll leave that to other people. The drugs are too expensive, and they don't need to be. So at the beginning, we were told that antiretrovirals will cost us much. Africans can't tell time, so then they can't take antiretroviral treatment. It's unacceptable. So cost, we understand innovation, but we also know that you can make drugs available and companies can still make the money that they need to make. And the last thing is that you can't do silo treatment. So that's one thing that, you have someone coming in for hypertension care, for this care, for that care. Where possible, to integrate care services that you're able to get good outcomes. We saw this in HIV as well, where someone will come in, get HIV prevention care, but they are PrEP, for example, but they're not getting condoms. So teenage pregnancy is an epidemic in South Africa. STIs, syphilis is on the rise. So where possible, you need to make sure that you've got a comprehensive bucket of services available to people who need them. And the last thing, I think, around the lessons that we can learn is that people can make a difference. Because you think sometimes like, oh, the governments, they don't care about us, we can't push the needle, but we can. And through in South Africa, we've got a really good culture of civil society and people moving. Something that makes me proud to live and work in a country where people push. And if you push, you can make people. So I always laugh when they say it's impossible. COVID-19 showed us how things can move, right? Because before people tell you, oh, wait, etc. How long did it take for people to get jabs in their arms, right? It showed that when people get together, you're able to do something at scale. So as we look at these novel treatments in South Africa, what are some of the opportunities and the challenges? Can we include this in our national formulary? So the obesity angle probably won't work. The diabetes angle is more compelling, given the data that I talked about. And also, how can you use them to get broad-based benefits that Sylvia spoke about? We need evidence-based guidelines for NCD management, and we also need an appropriate mix of medical and other sector guidelines as well. Generics, if they can come on board, that really makes a difference and can drive down the prices of these new and exciting medications, and also to simplify access requirements. Some of the challenges, cost, cold chain, but we also have orals that are coming up, training and upskilling healthcare workers. Because one of the things with HIV, it was easy. Layperson could do it. How can we do the same? Diabetes is a more complicated medication. And then conflicts with an environment where you still have a lot of communicable and non-communicable diseases. Healthcare workers are also it's always the same nurse, and you're adding all these other things that she or her has to do. So, and patient concerns, which is quite interesting from the South African perspective when we look at weight stigma. So some of these new drugs, you can lose up to 25% of your weight in a short space of time. What does that mean in a background of HIV-related stigma? So if you lose weight, the first thing, even on funeral programs, if someone has passed away, they will say they passed away from heart failure. I'm just like, why are you guys putting it there? It's like, so people don't think the person died from HIV. So HIV-related stigma is still pervasive in our society. So one of the things in the trials that we do where people are losing weight, people are concerned. I want to lose weight, but if I lose too much weight, what does that mean? So I'll hand back to the chair. I'm done.
Namatemba, thank you. And I think lots of us feel the action of people in South Africa also, enabled what we now have in terms of the numbers of people on treatment. So thank you for that. Lena, over there. So Lena, I think, is going to give us more, a perspective from India, but some of the more legal angles perspectives in terms of how we can think about getting access to newer medicines.
So I'm the outsider here, and definitely I think I was completely inspired by what was presented from Ukraine and Gaza. And of course, you start thinking about what you can do about diabetes, not only in terms of just conflict, but also among marginalized communities. And this is where I really work with drug users. Some of my coolest friends are actually drug users. We just hang out all the time. So I just wanted to say this, that it's just amazing to come here and feel the first sparks of a movement, and just share what, as an outsider, what I feel that we could do to strengthen the movement. So I just wanted to say this, that Dr. Jonathan Mann, he was absolutely stellar in bringing the whole justice issue into public health, and he just basically put it all down, that health is a human rights issue and human rights is a health issue. So I think this is really very important. How do we frame issues around diabetes and the impact it has on gender, children, in conflicts, around justice and rights issues? And I think it allows other movements to connect and come and become a part of this very important space. So there were one very important thing. We brought rights into public health, So I think this is really very important. Bringing the rights framework of why you need to treat the individual patient to make an impact on public health is absolutely important. And why you need to reach the most marginalized first, for screening, for providing the tools that you need to, so that you can actually have reduce mortality and morbidity due to diabetes is also very important. And we made these arguments at a time when we were actually working with drug users, sex workers, men who had sex with men. And these are incredibly hard conversations to have. Can you imagine in India when you're talking to a male member of parliament and you're telling him that we want to provide services to drug users? And we started these incredible important discussions at a time when there was a lot of stigma, not around HIV/AIDS, but also the marginalized community. And of course, what drove a lot of us from the feminist movement was that I was part of the sex positive movement, sexuality movement, I am still, But we also worked on SBGV, and we recognized that diseases, particularly like HIV, and now I think I've seen women who take care of children with diabetes and what impact it has on them, and of course themselves when they are diagnosed with type 1 diabetes. So I just wanted to simply say we can't ignore these links, and then we need to use these links to strengthen the community that we have. I think we need to start discussing this. Why are these medicines so expensive? And I'm so very glad that the data on cost of production is out there, and putting this question right in the faces of policymakers and a lot of people who can influence the way the pharmaceutical industry works and how the market can be shaped. And I think at the forefront of it, of course, were patients and people living with HIV who refuse to accept these arguments about something being too expensive. And I think sometimes when I listen to the argument about analogs, it just reminds me of that conversation. Because why are we pitching, vials versus analogs? And that's a failure of us not seeing the larger issue of a couple of pharmaceutical corporations controlling the market, and irrespective of whether it's going to be vials or analogs or GLP-1s, they're going to do the same thing. So you need to start thinking of strategies to work around it, and challenging monopolies, pushing governments to take action. And I think what I learned from people living with HIV was they didn't want to discuss whether it was cost effective or that it was in public health. They said, we want to go to court because I have a right to live. And that's how the whole battle started. And I think this really forced governments to do something about, changing the outlook towards just this constant discussion that we have about, does this benefit public health? Is this cost effective? These are important arguments for public health programs. Nevertheless, individual patients can make a huge difference when they go to court. And what reminds me of this is the discussion about the strips, the monitors, sensors, and the drugs. So someone is giving insulin, but not the other two. Someone is giving the wrong type of insulin. I would take this to court. Which judge is going to say no, that I will not give you the strips, I will not give you the sensors, and I will only give you insulin. So I was thinking, why are we not going to court? Because I just want to tell you this. Working with human rights lawyers was incredibly important for the HIV/AIDS movement, because we first went to court when people living with HIV were incarcerated. Sex workers in India, people who had donated blood and got diagnosed. Then we went to court because employers were chucking us out, people living with HIV. Then we went to court when kids couldn't go to school. And all of us lawyers who did this work are now totally part of the movement. And you can call us and say, there's a problem, and we'll pick up the phone. And you can be a judge and very senior lawyer, and you can imagine this immensely powerful network of human rights activists who have been talking, HIV activists have been talking to them for 2 decades. And you can get justice because you know whom to call. And I think this is the beauty of the HIV/AIDS movement, is that we were able to call the feminists, we were able to call the LGBTQ activists, we were able to call the judges, we were able to call the lawyers. We were everywhere. It was an interdisciplinary movement. So we co-opted everybody. A leading journalist in some place, everyone was part of the movement. And I think this was so beautiful because 30 years later, we are still delivering results because of this interdisciplinary approach. And of course, we were so hell-bent on, we were stuck between governments and pharma companies. So we had to shame both, and court cases were wonderful because we could mobilize around them. Of course, collectivization, I've seen the brilliant work that T1 has been doing, and of course, framing it as a rights issue, and we can, of course, work around supporting and building on these dialogues in our own countries, in South African, Indian, and other contexts. So one of the successes we had was bringing down the cost. I'm sorry, I stopped counting at July 06 because now it's, of course, half the cost, maybe less. But I just wanted to say this, when we started, this was a charitable price that the companies were giving us. I'm not going to name them. 10,439 for MSF. It was much higher otherwise. The Brazilians came in with local production, 2,767. And then the $1 a day deal happened with one of the Indian generics. All of this, we had to fight the patent monopolies, and I just want to come to that. So many people think patent, voluntary license, MPP. But that's not the trajectory of the South. The trajectory of the South, the truth of the South, our history is the first time we discovered, as treatments were being scaled up in South Africa and many of our countries, that the backbone of treatment, lamivudine, zidovudine, which was just a fixed dose combination of two old drugs, there was a patent claim in India. And we were like, oh my God, these drugs are rolling off the factories. And what if a patent is granted? GSK is going to kill generic competition, and we are going to be stuck with programs without the drugs. And I remember the time when MSF actually said, this is the backbone of treatment. Can you find the patent claims? And I was laughing because I was like, we are not chemistry experts. And two lawyers said, come on, Lena, we can do this. And I was like, chemistry, I hate it. But 20 years later, I'm still doing it. So I just wanted to say this. It's not a new invention to combine two drugs. Okay, so what did we do? We filed a pre-grant opposition in the patent office. We had never done something like this. And we learned it actually from a Cancer Patient Aid Association who went to court for imatinib. And the combination had a glide and sand. So what did we do? We took sand to GSK office in Thailand and India, and we chucked it on the doorstep and blocked the entrance. In the meantime, our lawyers had filed the pre-grant opposition. We went public, and GSK said, okay, we are withdrawing it. So that's what happened. Same with tenofovir. I'm not going to go into the chemistry angle of it. TDF was already known. It was forming a fumaric salt. You always pick the most stable crystalline form of a drug, not rocket science. Fumarate salt, for example, bedaquiline is a fumarate salt. So we knew that this was not novel. It was obvious. And we went to challenge the patent again. Again, it was a collaboration between human rights lawyers and people living with HIV and chemistry, organic chemists. And we filed this in May 2006. Within a few days, Gilead came to give a voluntary license to Indian companies, and in parallel, the MPP was being formed. We did this for dolutegravir as well. WIV was not coming on the table for any negotiations till they knew the Indians were going to win the pre-grant opposition. So we had them over a barrel. We've constantly used that tactic, and we'll continue to use it if the law favors us. So I just wanted to say this. This is how we did it. And now I just wanted to say this. You've got, SGLT2s going off patent. So that's good news, right? We don't have, maybe we have lesser of a battle going there. But GLP-1s, we probably have a big battle coming. So while people sort out the guidelines and, WHO figures out how they're going to deal with the EML issue, whether all the technical work that treatment providers, medical experts, and WHO, along with public health people can do, we need to parallelly look at what's going to happen. So GLP-1, semaglutide pen, already Indian generics have framed a way of doing the devices, getting the injectable factories up and going, raw materials are being made, all of this is being made. But of course, what you're going to see is big pharma come after them. They were already sued in the United States. So are we going to just walk away and say, you can have your patent, and South Africans can't have it, Indians can't have it, Thais can't have it, Brazilians can't have it? I think we will have to deal with the whole issue of patents, whether we like it or not in the diabetes context. And we will have to look at the monopolies that these companies have. There are oral drugs, which are patented till 2038, 37, 36. We will have to look at compulsory licensing, and we will have to fight that battle again as South Africans, Indians, Americans, Brazilians. So solidarity over here is going to be immense. The legal work that needs to be done is very important. And of course, the pressure that we build will perhaps lead to some voluntary licensing if we are successful, but we still have to work with middle-income countries excluded from those voluntary license. So what I want to say is this: we will have monopolies. We have monopolies on the newer drugs that we need to start being cognizant about and having a strategy among ourselves. So who's going to do this work in the United States? Who's going to do this work in India? Who's going to do this work in Brazil? We need to identify the groups, talk to them. These are human rights lawyers who have done patent challenges along with patient groups. Is it going to be people living with HIV, with diabetes, who are going to challenge this monopoly? How within the diabetes community are we going to be part of this whole process? So this is really very, very important work that I would say that needs to be co-opted into the diabetes movement. So the insulin double standard. Luckily, I come from the South. I don't have to be diplomatic. So I just wanted to say this, that the use of insulin analog is the norm for people. Now, if I had diabetes, would I take a vial? And I always do that test on myself. I know I will not take the vial and the injection. I will use the pen. How can I then advocate that millions of people in India continue receiving the vial from the public health program? So we need to look at the double standard built into it. Rich Indians are using pens. Rich South Africans are using pens. Everywhere, rich people are using pens. And yet we advocate for the vials to be in the public health program. And this is why the private sector takes over and does a shit job, in the sense you can then have a lot of irrational prescriptions going on and a lot of irrational work going on. We drive them into the private sector. We drive them towards irrational treatments. We also increase cost of out-of-pocket, 40 million people in India go into debt. We really need to start thinking that this issue of these issues of pens is also linked to the private sector and the disparities that exist within society, within our own countries. So I think we can't move away. And lastly, I want to say, if patients want it, who are we to say that you should take the vials, you know? And we heard it from the Gaza mothers. We heard it from a representative from Ukraine. And I've seen a whole lot of people with diabetes use the pens in India. But I also know that a transgender person or a person living with HIV is probably using the vials. So I know this exists in India, this double standard exists in India. I don't like it, and I don't think so we should be advocating for this double standard. So I think we need to think about this more and more, about how to unify around the issue of pens, whether it's human insulin pens or the analog pens. Solidarity, you know. The South Africans have opened a tender for the pens, 4 million a year. The tender is failing. Novo is not the only supplier, but actually has been the most consistent supplier. It just failed to bid and inform the DOH that they're not bidding. The DOH got a letter from the Society for Endocrinology, Metabolism and Diabetes of South Africa, that's SEMSA, that's quite a mouthful. And they highlighted something that we were debating. They said the use of vials and syringes can lead to dosing errors, which in some instances have fatal consequences. They highlighted it's absolutely needed for children and elderly, people with physical disabilities, and it could increase incorrect management of insulin doses. So that, you know, you've got treatment providers in South Africa pointing out to the DOH, you can't discontinue the pen. You've got a company who's not supplying it. What are we going to all do to support South Africa to get the pens from Novo? And I think we need to start working like that, so we can do this in Kyrgyzstan and Pakistan and wherever these companies behave like this. They choose not to just bid when they feel like it. I just wanted to say this interesting thing. Donations keep coming back in MSF. We keep having these debates. Pneumococcal vaccine, insulin, and I was looking at the WHO taking a donation of human insulin vials. So we are very grateful for this timely donation of insulin. Excellent. I don't know Dr. Bente. Okay. So guidelines on medicine donations says guidelines should focus on protecting recipient countries from inappropriate donation practices. Would patients consider this inappropriate? The guidelines should enhance the responsibility and involvement of recipients. Did the Gaza mothers really want this? There should be no double standard. If an item is unacceptable in the donor country, it's also unacceptable as a donation. Did WHO look at its own guidelines? Not at all. I don't think so. They read them also. And then, as a general rule, medicine donations are not a long-term solution. It has been found that bulk donations are more likely to be unsustainable and even cause harm in the long run. What are we doing about this? So I think WHO, if you really want to do something about the donations, think about the harm you're doing, but most importantly, get at least the donations right. So we can, use them in the right context. At least do that, Ask WHO to act now. The crisis, the humanitarian crisis are happening now. You're talking about an emergency kit which has vials and syringes in it. if people in Myanmar, in Gaza, in lots of the crises that are happening, the question of pens is being debated, then WHO needs to update its guideline. Maybe it's 2 years off, but maybe for the time being when humanitarian crisis is at a peak, you might want to consider it. And what about continuity of care? People are already on pens. So you need to continue the same standard if possible. So all of this is, I think, linked and in the hands of a very major agency that influences public health and member states. So of course, massive profiteering going on. And I'm not going to talk about it. Everyone knows. I can't buy Novo shares, so of course. Or Eli Lilly. But just look, 102 billion by 2030. This is just the GLP market. And the disconnect. So this is what is happening in US. The Senate Committee on Health, Education, Labor and Pensions call the prices of the drugs outrageously high. South Africa and opens an investigation. South Africa struggled to procure human insulin pens. We can add Pakistan, we can add Kyrgyzstan over here. And the disconnect from the WHO. WHO Director General says at the Global Science Summit, I congratulate the Novo Foundation on its 100th birthday and for everything it has achieved in the past century. We very much appreciate your support for WHO and for global health more broadly. There's a massive disconnect between WHO and the rest of the world and what's happening in our parts of the country. I'm not saying that WHO has not done stellar work. It has done stellar work. But I'm just saying on diabetes, it seems to be completely disconnected. And this is just one night of work that I did. We could just start looking at the conflict of interest and its private sector dialogue and the minutes and what they actually asked Novo and Lilly to do. And of course, the response of those companies. So this is the Novo building in Denmark. Of course, we could put Lilly there. And I just want to say T1 has been doing some stellar work. But it just seems that, this is the empire that Lilly and Novo and Sanofi have built. And it's the only people's power that will break down this empire that they have over the diabetes market. And this is just a perspective coming from HIV, which is not necessarily applicable always on diabetes. But I do think some of the ways, the tactics we've used in HIV are applicable in diabetes as well. Thank you.
Thank you, Lena. And I say, it just sounds, I mean, it's fascinating. I'd really urge you to go to the annual reports of these companies and you see what's happened in the last couple of years with GLP-1s and the profits that are being made from GLP-1s. It is staggering. I mean, Novo is the biggest company in Europe now, overtaking Louis Vuitton. They're making more money from GLP-1s than handbags, apparently. And Lilly is, approaching a trillion dollar company. Yeah, I think I'm right in saying. So GLP-1s are making these two companies at the moment extraordinarily rich. So do they have a responsibility to get what we're calling the basics right as well? Julia, over to you. We're running a little bit late, but Julia's going to tell us what Lena mentioned the medicines patent pool, and I just want Julia to kind of give us her snapshot of the role of the medicines patent pool, and specifically is how you're now engaging in NCDs and diabetes.
Absolutely, and thanks. I also want to thank Sylvia and all the IATA organization for organizing this panel and inviting us. MPP is another organization that starts with M, but it's not MSF. I just wanted to start with this. And I think it's interesting, and let me step back for just a second, because we've been talking about voluntary licensing, but at least to me, when I joined MPP 4 years ago, was not totally clear. So let me just try to explain in a sentence, if I can. So Medicines Patent Pool, what it is, it's a UN-backed organization. We are an international organization based in Geneva, one of the organizations based in Geneva that starts with an M. And we try to accelerate. Our mission is really to accelerate access to innovative, which means patented, medicines in lower middle income countries. And we do this through voluntary licensing, and since a couple of years also through technology transfer. Today we're gonna focus more on the voluntary licensing part, but for sure I'm more than happy to continue this conversation at the coffee break. So what is a voluntary license? A voluntary license is an authorization that a pharmaceutical company, a patent holder, which is normally a pharmaceutical company, gives to a generic manufacturer to produce, to manufacture and sell a specific patented medicine as if it was a generic in a geography that needs to be negotiated. What does the Medicines Patent Pool? Medicines Patent Pool engage in this negotiation and define the terms and the condition of the license, which means, for example, the geography of the license, but also the amount of transfer that can be, the amount of technology that can be transferred within the license to further accelerate accelerate the development of the generic version of the drug, but also to reduce the cost of development, hence further reduce the price that can be applied later on. So as I said at the beginning, what we try to do is accelerate access to more affordable medicines. Accelerate because through a voluntary license, ideally, patients in lower middle income countries do not need to wait until a patent expires in high income countries to have access to the generic and more affordable version of that medicine. The example of Glargine, I think, available in the US in 2000, and arrived in lower middle income countries in 2024, this is exactly what we are trying to tackle. So this is exactly the type of acceleration that we are trying to tackle. The affordability. Well, the generic version of the drugs are always more affordable, and this is very well known. But what we try to do is, when we select the generic manufacturers we partner with, we never select one. We don't want to reiterate any monopoly, right? We try to engage with the highest number of generic manufacturers that we consider appropriate for that specific market, so that prices can be further reduced because of the competition that is created across different generic manufacturers. So this is how it operates. How do we select the medicine we try to work on? Well, this is one of the most sensitive aspects of our work. And just a full disclosure, we don't do it alone. I want to really make sure that everybody goes home with this message. So we put together a robust prioritization framework, which is the process that we use to collect information, which basically allow us to answer to three key questions when we select the medicine that we think it's important for us to work on. The first one is the clinical and the epidemiological part. So does the product address an unmet public health need in lower middle income countries? And this is the science, but not only the science. So it's not only through the partnership with scientific society and WHO, the organization starting with a W, that we try to answer to this question, but also engaging with people with lived experience. And we launched last year a community advisory panel, and the role of this community advisory panel is fundamental for us, because it's not only science, but also innovation comes also in newer formulation, in newer devices, in newer way to administer the drug. So we want to make sure that either we tackle something that it's important, or that we deprioritize something that is actually not important for a patient. And the second question is to try to understand if a medicine is important and it does tackle an unmet public health need, we need to understand if there's actually an access hurdle, because it might be that there is not for some reason. Well, it doesn't happen that often, but it might be. But then the third immediate question is that if that access barrier can be tackled through an MPP intervention. And unfortunately, the answer to this question is often no, because we tackle intellectual property issue or technology transfer, so complexity in terms of manufacturing. So sometimes we need to acknowledge that even if there is an unmet need, we are not the right partner to try to tackle it. Fortunately, but we also need to do that. In terms of diabetes and cardiovascular, well, diabetes priority at the moment, we identified, well, very consistently with what Sylvia was presented, we identified a class of incretin-based therapies, and we are, for sure, exploring both GLP-1 and the newer ultra long-acting insulin. That's the name, right? Is it? Well, the once weekly, so yeah. Once a product is prioritized, what happened? How does the prioritization bring to access? And as the previous panelists, I'm going to bring you a practical example. I really think that practical stories are very, very useful to understand what it happened and how things can be implemented. And it's another HIV story, the DTG story. I think it was already mentioned, Nomatemba mentioned it in her slide. In 2013, a new era in the HIV treatment arrived. And if I'm not wrong, it's integrase? Is it? Exactly. So in 2012, I think, the WHO, through its CADO processes, identified dolutegravir as one of the most relevant candidate for HIV. In 2013, dolutegravir received an approval by the US FDA. In 2014, MPP managed to sign a license with ViiV Healthcare, the originator. And then 2 years after, so 1.5 years after our license, WHOPQ issued an expression of interest, which means that a regulatory pathway was available to register and assess the quality of the generic version of those drugs. In 2016, it was included in the WHO guidelines, and in 2017, if I'm not wrong, it was included in the WHO Essential Medicine list. So I don't want to go into the details of all the story, but what I want to tell you is that the license has we currently celebrated the 10 years of this license, and since 2013, when we signed 2014, when we signed the license until 2024, this license allowed access to DTG or fixed dose combination that were containing DTG to 24 million patients in 127 countries. How did this happen? So it's a collective effort. So this is the message of this slide, and I'll try to speed it up so that we can leave some time for the questions. But there are two key aspects that I really want to underline here. And one is the early detection of the candidate, of the intervention that that could have been relevant from a public health perspective. And the second is the alignment of all the partners, because all the partners, from WHO to civil society to patient organization, we were all allowed. I was not there at the time, but I feel part of the team. So we were all allowed to work and to make this happen. So. And there are so many similarities also with what's happening with in the diabetes field right now. So when DTG arrived, it's not that there were not ARVs available in lower middle income countries, it's just that they were less effective. So nobody wondered and nobody challenged the fact that HIV patient in lower middle income countries were deserving better therapy with better safety profile and better clinical outcome. And that happened. So the license was signed, but because of this acknowledgement from a global health environment, and so the more affordable version of the generic DTG arrived, but then it not only arrived the generic version, but it met a regulatory pathway that is available, and it's not available for many NCD medicines. So that's another issue we should try to tackle more, because this is something that is missing. We can make it happen. It happened for the HIV space, so it can happen also for the NCD space. There was a prompt adoption from WHO guidelines and from the EML. And the civil society played, and the patients, and that created the political will, which was fundamental to drive the transition at country level. Without that movement, the uptake wouldn't have been possible. And last but not least, the alignment across all the other global health partners. So I know that we don't have the global fund in the NCD field, but we do have other partners, and everybody worked together. The global fund, UNITAID to create additional evidence, CHI for uptake mechanism. We all work with the same objective to improve access to DTG. So the strong message that I want to bring is that it's complex. Improving access to NCD medicines in lower middle income countries, it's complex. We learned a lot from the HIV space. There are some aspects that we can try to replicate, and we have the name and the surname of what are these enablers. It's still challenging, but if we work together with an early identification, with a strong alignment across partners, we might manage to replicate the DTJ case study in also for neurodiabetes medicine. And that's all. So.
Brilliant. Thank you. Thanks, Julia. So I want to kind of open it up to the floor, see if there are any questions. Hands going up. Excellent. Is there somebody with a mic wandering around? So I'm going to I'll take 2 or 3 questions, try and keep them to the point. And then, and also if they're to a specific panel member, even better. And then we'll answer. So I'll take 2 or 3 questions. So Molly, do you want to, Molly from Hi, take the microphone?
Hi. Thanks for the presentation. And I mean, I agree a lot of the fighting and the language matters, analogs, human, whatever. The point is, they're all old medicines. I mean, I also hate when people say designer drugs. Clinically, if they're all the same, then they should all be the same price. And that should be the end of it. It shouldn't be a discussion about this one's better, this one's worse. It should be everybody should be able to have access to pens and to, if they want to use syringes, to the choice of what they want for a person living with diabetes. And I think sometimes you can demonize one to help the other, and the truth is a lot of people make a lot of different choices of how they live. But that's not my question. My question is more about with the patents, also the device patents. So we did a study with Aaron Kesselman in Harvard, and he found that in 2020, 60% of patents are now on the device, the delivery device itself. And I mean, every pen has a completely different situation, and I'm wondering, what can we do, I guess, from an advocacy perspective about that, and how can we push for maybe some sort of device that's a universal device rather than having to go through this with every insulin and GLP, et cetera?
Brilliant question. I'm going to take that one. Alina's going to answer that one. I apologize because I forget your name when we were chatting
Sana.
yesterday.
Yeah.
So welcome.
So my question, and thank you so much, Molly, for pointing this out. I was going to pick up on this as well. So for example, a very practical example is that someone having Somogai effect may need NPH, while someone having late night hypos may need basal insulin. So we have to make sure that that there is a diversity of availability. But having said that, my question is to Lena. Do you think that there's any way to legally pick up on these companies for taking away the capacity from insulin production towards GLP in the countries that they're producing in?
Another brilliant question, which we've certainly been bouncing around the last few weeks, yeah. James, and then Serene, and then I'm going to bring it back for the panel to answer. So 2 for you, Lena, sorry. James?
Yeah, hi, thank you. Really interesting presentation. I think, in some ways I agree there's a lot to learn from HIV. I think the biggest glaring difference, right, is that there's a lack of central buyers. There's a very fragmented landscape in terms of when we talk about demand generation, for example, there's a really diverse landscape of partners. And so that becomes a major, major issue. I think the other critical thing I want to point out for this discussion is that when we're talking about product introduction of new products, innovations, that's never, ever going to happen in humanitarian settings first. And so sometimes you need to lead with, countries, BRICS countries that we talked about. My question, which I think is probably best posed to either Helen or Julia, since you guys talked about this overarching framework, this need for alignment across different steps of the chain. I'm curious if you guys have thoughts about what is the mechanism, the process, the functional secretariat, whatever, that is going to make that happen for the diabetes space, because we don't have the same central funding power, the same 2 to 3 philanthropic donors, that kind of thing. What is your theory of how that could work in this setting?
Brilliant. Okay, and then last question from Serene.
I just want to say first, Lena, you're an absolute hero. Thank you for your presentation. One question that I want to ask is, when you were working with people and trying to advocate, or like through your whatever you read on AIDS, did you ever come across ethical committees within pharma companies and how you would actually access them to shift the ethical considerations that these pharma companies take when they price or when they give grant access to patients around the world?
Okay, thanks. Really great questions. Thank you. I'm going to give the mic to Lena first of all. Yeah, and then I think Nomatemba, maybe you also have something to add to Serene's maybe. Anyway, last point. And I'm going to let Julia answer James's question, and James and I can have a coffee later as well. Lena.
Yeah, so I just wanted to say that, part of the legal solutions we are looking for is to take the lawyers through a treatment literacy session. We don't understand what you are talking about, okay? And this is really coming from a lawyer.
Just started.
Yes.
It's taken me a little while.
I'm constantly Googling and trying to figure out what is what, just to try and catch up with the conversation. I just want to tell you this. So if you want to do what we did, is to do a treatment literacy and the access challenges and stigma and discrimination with lawyers. And just to give you an example, the thing that really got me hooked was this conversation with another diabetic about schools not giving admission to children with type 1 diabetes. Then when you manage to convince the school, the school saying, keep the child at home, just get the child for exams. Number 3, if you come to school, the mother has to sit outside, okay? I was blown. I was completely blown. What do you think women are, I got really angry at that point. And I said, you're doing this child by child? They said, yes. I said, why are you not going to court? That's how I got into diabetes, because it was a rights issue for me. And I think lawyers need to be taken through the whole process. If you do a treatment literacy, then we can draw up different buckets, the stigma and discrimination, the right to employment, education, and the challenges that you are facing with supply. And I think this is what we really need to do, is do a solid, thorough workshop for lawyers, human rights lawyers, on treatment literacy relating to diabetes. And yes, there are different solutions, but I cannot say I can advocate that, the situation in Pakistan, the situation in South Africa, the situation in this thing. We need to talk to local lawyers about what legal tactics we can use, and also what advocacy we can combine to make them, force them to supply. So that's the first thing I would look at. And then we look at price control as a mechanism. There are different mechanisms. So different strokes, different countries, I have to say. On the devices, I wanted to say this, because the very interesting question, because when the semaglutide pen issue was being discussed, I thought this is going to be a big challenge. And then I went to the generic companies and I spoke. All of them are working on it. They're going to come up with their own pens to beat the device patents. But having said that, I think, again, product by product, which are the ones we are really targeting, and which are the blocking devices we need to identify. I think the only organization I know who can do this work along with you all and partner is IMAC, because you need to take the analysis to the generics and say which really blocks you, and then go and challenge it, whether it's a compulsory license or a challenge. So we need to take this beyond and figure this out a little better, I have to say. And we need resources to all the funders. So I just wanted to say this, that's it.
Sorry, but that's a very interesting question. But do you think that the capacity, sorry, Ellen, but do you think that the manufacturing capacity of the generic version of device is enough, or there's something that needs to be done also in that regard?
Well, I mean, insulin is, I think, slightly different. But with the injectables, the Indians are, because it's such a blockbuster drug, profits are also driving them. They are putting in the money. They've got the investors convinced. So I can tell you every big generic company in India is working with some device maker trying to source a very established API producer and trying to knock on the doors of the US FDA, because that's where the money is to be made. That might be a very good benefit for us, because they're all queuing up to make it, and then we move them towards LMIC. So what are we going to do the market shipping for? I don't think so the device patents will stop the Indians. They will break the patents if required. They are raring to go. The Chinese will come as well. Everybody will come. It's such a big market. And we need to be there to use this to our benefit, I think. So this is where I am on devices. I think Americans have already, Novo has already sued 2 companies in the United States, and we need to look into the device patent over there and get into that fight, I think. So that's what I'm.
Julia, just maybe a comment to James's question, which is really super important because it's no good if we don't do this together and there's a clear pathway, yeah?
It's the question, honestly. So, no, I just want to comment one thing about humanitarian settings. And yeah, I totally agree. I wanted to cut a bit of the granularity of the thinking, but just for you to know, one of the reasons for which we are targeting some oral compounds is also because they do not require cold chain. So what I'm trying to say is that there are some innovation that actually can become relevant for humanitarian settings. So, but that's, and again, I'm happy to have another coffee or a glass of water for you not to drink too much coffee afterward. The convening power. When we were preparing this panel, and I can tell you there was an extremely interesting conversation, we were also discussing about what could have been the outcome, what should have been the outcome of this panel. And we all agreed saying that we should start writing a roadmap. And it's not an answer to your question, but it's the first step of something tangible that we could try to make, because my personal opinion is that if we keep on discussing about access, but we don't name the specific barriers that we are trying to tackle, well, it's going to be difficult to go ahead. So the desired outcome of this session, or I mean, other session, is really to start drafting a roadmap. We don't have an immediate answer to who has the convening power, who has the possibility, the bandwidth of putting everything together, but the first step that it's within our capacity at this stage is at least start drafting a roadmap. Everybody can join, so if you if you think you can contribute, that's more than welcome. And at least that's a first tangible step that we can use to seek for secretariat or an organization. But I think that we really need to start working on tangible aspect, all in parallel, because everything, honestly, everything needs to happen in parallel. So we can't wait for one thing to happen to start with the other one. We want to accelerate access, not to wait until 24 years pass. So.
Am I allowed to take more questions, Anna? There's two more questions. Oh, there's lots of questions. I think there's going to be lots of questions over the water, wine, coffee, whatever takes our fancy. Can I take 2 more? And I don't know who. Oh, somebody's already got.
I have the mic, and it's just.
Claudia has the mic, and then I'm going to let Emma. Saita, you've asked quite a lot of questions, so. We love your questions. We love your questions. Claudia.
Yeah, mine is not a question. It's just a comment and a bit of a plug.
Commercial.
Novo's once-weekly insulin has been mentioned quite a bit. End of the year, we will have the Access to Medicine Index. That is a project that it is within the pipeline. And we will be asking the company to report what type of access plan they have for low and middle income countries. So end of the year, there should be some data available about what is it that they're planning to do in terms of, if anything, registration, and I know there's a comeback, or even equitable pricing strategies. If we can equip anyone with those findings, yeah, do reach out to me.
That's great, but I think we also need to tell them what we want in lower middle income countries. Emma, last question. Oh, Saita. Okay, Saita. I'm going to take the chair. Can I take the chair's program? I feel bad with Sylvia next to me. Saita as well. So Emma and then Saita, and then we'll close.
Sure. I just wanted to bring it back to the human rights perspective. So over the years, Life for a Child has developed a practical human rights toolkit and developing in other languages other than English, because I think accessibility is super important. But basically, we've developed a toolkit in collaboration with some human rights practitioners really around demystifying, what are your rights as a person living with diabetes. And I fully agree, with your point, Lena, but I think that, diabetes associations and healthcare professionals alike really, there needs to be bridges built, I believe, to demystify, the language around human rights. And we need to have, practitioners and these local stakeholders getting trained up together.
Yeah, no, great comment, Emma. And Saita,
Yes, sorry.
last but not least.
So, apology to asking questions, but no, it's true that I really appreciate the good medicine should be available regardless of the place where the patients are, Gaza, New York, wherever, or Athens. But my question, I just want to be honest that is this the lack of access to insulin or GLP-2, GPL-2, whatever, is the problem that, in other words, that having access to the insulin, that everything is okay? Having the access to GLP-2, is that correct? GLP-1, sorry, GLP-1 solve all the problems? Probably not. And Sylvia, questions to you that because I checked ADA guidelines while you are talking. It is true that insulin is not the first line; it's second line. And then, but this is not in our case. And so looking at the HIV/AIDS and also TB, which I know better, see history that there is always activists, but together with a package of services. Because that having access to the critical medicine without packages, we end up another one. Say like TB, we end up with the MDR TB, in simply like this. And so that for diabetes, I think what you have said is very clear, although complicated. I couldn't understand the many of the ADA guidelines. I need a chat GPT to tell me what it is. But still, I think it's important together with WHO, we make a package. And then so that to implement the package, which not only the diagnosis, treatment, but the monitoring, evaluation, all the package, and then activists can tell that I don't want to die for this GLP-1. So I think that's more important. So what do you think? Because what you are saying is totally different to what we hear from this part of the world, and we never heard of GLP-1. Yes.
Yeah. No, and I definitely acknowledge those guidelines are EASD, so European and the American Diabetes Association. Not all diabetes associations have adopted that model. There's different ways of looking at this. I think, yeah, in the United States right now, GLP-1 agonists would be the first-line injectable agent. I think the point that we're trying to make here is that, yeah, there needs to be, it's early days with GLP-1s. Let's face it, my patients in Boston are not getting their drug because of back orders and stockouts. So this is a conversation that isn't necessarily GLP-1s in a humanitarian setting. It's not happening in the very near future. But there are so many drugs in the pipeline. Like the small molecule, I think orforglipron is the most close to, I think it's in phase 3 trials. That has some significant potential to really shape type 2 diabetes management and potentially even type 1 with high cardiovascular risk in very low resource settings. And so those guidelines will need to be developed. I mean, even like high income countries have conflicting opinions on this. The point is just there are phenomenal drugs in development, and unless we start thinking about this now, like what's out there and what might be useful, it's not going to happen, right? We're seeing this now. So that's kind of the point we're trying to make. Not everyone needs to be on injectable GLP. That's not what I was trying to say. But it is complicated, yes.
And so if I just go back to that exercise that we're starting to do with our projects, very practically, thinking about, R&D, patents, but at the same time, I need the supply chain, last mile, and I need differentiated service delivery models to get those medicines into people's mouths. But to do simple service delivery models, you need the tools that are less toxic, less pills, don't have a complicated supply chain, less pill burden for the patient. The reason we scaled up HIV is because we had something simple that nurses could give that didn't have a load of side effects. And so as Sylvia says, there are things in the pipe that could make the service delivery package, more simple and, dare I say it, less costly.
No more questions?
Wants to, yeah, I just wanted to say two things. That when we started to do the work on DRTB, bedaquiline was just DMC 207. We didn't know it was going to succeed. But we filed a patent challenge in India in the hope that if it succeeded, we would have a pathway to access. And it did. We won that case right at the moment when BPLM was going to be scaled up, and those were like moments of joy because you had worked decades on those strategies. So I just want to say we need to think very early on. I agree with you now. Maybe 3 of those will go out of the window, but we still need to think about them. And I wanted to say that the only access plan from Novo, and I'm sorry to be so straightforward, is that you make it affordable so that public health systems can absorb them. Anything less is not a benchmark for an access. We don't want charity. We don't want it for a few people in India or XYZ. That's there. And thirdly, the things that on ethics and companies that you asked me and I didn't answer it, is that companies don't have a compassionate use program for many, many countries in the South. And what we did with viral hepatitis was the thing was that MSF knew all of these people, right? So I just stole everyone's emails. And then I started to write individual letters for compassionate use for SOF and DAC and all the other drugs. And actually it worked tremendously for MSF because when we as Indian patients started to ask for compassionate use, it opened the doors for MSF to get compassionate use. So we use compassionate use as a tactic to open up access for viral hepatitis. And that's when the ethics committees we came across ethics committees in pharma companies who would look at the papers. Gilead said, unless it's a liver transplant patient, we won't give you compassionate use to SOF and Velpa. It was heartbreaking because you had 2 patients who had undergone a liver transplant who could SOF Velpa. And then we went back and wrote a letter to the committee saying, you are being unethical by denying a life-saving treatment. And the compassionate use program guidelines got changed. But it's incredibly important to know that organizations actually who have access to big pharma are able to help activists like us to do the work that we need to do in our countries. So I think it's just a partnership, as a lot of people said. So we did that in viral hepatitis. So you can reach out to companies and the ethics committees to say that your so-and-so guideline is unethical and we think you need to revise it. So you can do it if you have the right case and the right frame for it. Yeah. And same for clinical trials. Post-trial access is such an important issue.
Okay, I think I'm getting the evil eye from Anna, as much as Anna can give me an evil eye. Thanks a lot. Really good, great questions. I think some food for thought. I think several actions for us and all of us together to think about how we kind of move this conversation forward. Continue to have chats over lunch. As I say, I'm going to go for this year. There's going to be a once weekly insulin. When are we going to have access to it? So you're going to tell us where we're having lunch, are we?
So it's lunchtime, and lunch is going to be where we have breakfast on the top in the rooftop area. So 7th floor. Just follow the crowds if you haven't been up there yet. And after lunch, we're going to have our workshops, and because it's not going to be go straight to whichever room, and there will be signage down here. They're all right close by to this room. But the 4 workshops, one are on financing, so Jay and Rachel will be co-leading that one to continue the conversation on what should we be doing next, even if it's a small step forward, like what should we be doing next in that space. One is on access to diagnostics and devices with Jing and Helen. One on discussing a minimum initial or a minimum service package or toolkit for diabetes that Philippa and I will be co-leading. And then one on a rapid multi-agency diabetes needs assessment, like a sit rep essentially for diabetes. Maybe take a screenshot of this, the different rooms. So just head straight there after lunch. It'll start at, I guess at this point, it'll be like, 1:45-ish? So we'll cut a little. But the workshops afterwards will convene, will present. There will be one presenter per workshop on what the group decided as a outcome, next step, what we want to do. And then we have a visual artist that will be putting this all together in visual representation here. So, and Tom Ellman will be facilitating that. All right, everyone enjoy lunch. Thank you.